Well, thank you all for joining us. I'm really excited to be here with the PD Pals, Dr. Samira and Dr. Anna, or is it Anna?
Yes, Anna, that's perfect.
Anna, okay. And we're going to be talking about where baby sleeps and how that relates to sleep safety today. Would you ladies like to introduce yourself?
Sure. So I'm Dr. Samira Arman. This is Dr. Anna Powell. We are two board certified pediatricians. We live and practice in Houston, and we're also best friends. We refer to ourselves as the PD Pals. And yeah, we're happy to be here talking to you today.
You can find us, we have our podcast as well. So we talk about a lot of stuff, about pediatrics, just raising children. It's so difficult in this time. And we connect with Dr. Leah and we got along instantly. And so thank you for having us, because we can definitely relate about, there's a lot of misinformation out there. So we appreciate other fellow doctors and physicians and providers that are taking on this, online journey to kind of clear up some misinformation and help parents. So thank y'all.
Yeah, thank you so much for being here. So, one of the things that a lot of parents worry about when they are about to have a baby or have a newborn is just where should the baby sleep. I know the American Academy of Pediatrics and other sort of official recommendations say to have your baby in your same room, but not sharing a bed with you. Could you take a moment just to explain what that recommendation is based on?
Most academies, not necessarily just the Academy of Pediatrics, but most do recommend safe bed sharing, and that is to reduce the risk of something called SID, so sudden infant death syndrome, which is a condition, and at least in America, one of the top leading causes of infant mortality under the age of 1. And a lot has been done in terms of trying to study and understand SIDS, and it is still a bit of a medical conundrum. Basically, we still, as a medical community, don't understand why, very rarely, but sometimes babies will go to sleep and not wake up. And a lot of research has been done into this, and we've learned a lot in terms of how to minimize risk factors. But the whole way that SIDS is explained, essentially, is that it is a situation in which you cannot identify any reason for that to have happened. So like there was a full history taken, a medical examiner looked at the scene, there was an autopsy done, and they cannot identify that it was due to like suffocation or something that happened. It's completely unclear what led to it. And so because of that, a lot in just this is a global issue. So in many countries, a lot of research has gone into it, and we've been able to identify a lot of risk factors, but still not identify exactly what happens to the babies during that time.
Yeah. And, the reason that we talk about this and we provide kind of information and we call it anticipatory guidance for families is because, we see 3,500 on average babies that die suddenly and unexpectedly. And so we might not have all the answers as to why it happened. And of course, we're both, women of color. We've been raised, by families that immigrated here. And so we totally understand that this is a complex topic because most people around the world from different cultures, bed share and co-sleep. And it's one of those things that's, termed controversial because so many cultures around the world do it. But, in the United States, we see these children that die unexpectedly. And so a lot of research and time and money is put into trying to identify links or commonalities between these cases. And so kind of our job as pediatricians is to provide parents with those risks and to try to give parents all the knowledge so that they can make the best decision for their family, because, that's kind of our primary job. So it's not, to really judge people and their living situations and where they come from. It's just about presenting the facts, telling them the risks, seeing the consistencies that we see in the research, and then letting people make a decision for themselves and their families. pretty much what we do.
Yeah, and I want to expand on that because that's really well said. And at the end of the day, that's what it is, right? It's your life, your family, your baby. A pediatrician's job is to support you, not judge you, and to offer you information based on our medical background, essentially. And so that's all this is, and at the end of the day, everyone knows what's best for their family and themselves.
Mm-hmm. Yeah, thank you for that. So I kind of wanted to just give a little bit of background about SIDS. So the incidence in the US is about 0.03%, so not 3%, 0.03%, which means that it's happening to about 1 in 3,300 babies. So can you talk about, you mentioned different levels of risk depending on how the baby is sleeping. So what is considered as sort of like the safest option, and what is considered more risky, and how do you advise patients, or I guess more parents than the actual patients because they're very young, about how to make that decision?
Yeah, so it's it's really interesting. And it definitely seems to be something that might be related to hypoxia or lack of oxygen intake. Babies who are born low birth weight or premature have a higher risk. There are definitely some racial and ethnic differences that have been identified as well. It seems that male babies are a little bit more risky to develop SIDS than a female would be. We've identified more cases of SIDS in like cold weather, higher risk in like cold winter months. And then there's a lot of maternal risk factors too, such as if the mom is a young or single parent, if she had pregnancy complications or poor prenatal care, even if she had like anemia, but especially the biggest one that we talk about a lot is smoking. Smoking is a risk factor that really is associated with a higher risk of SIDS. And then the baby can have risk factors too. Prematurity, being low birth weight, as I said, being a twin. And then the thing that is the most easily changeable that can be done from a parent standpoint is the sleeping position. So sleeping prone, it gives you a twofold increased risk. And as sleeping supine seems to be safer. And actually a lot of countries, including America, and some parts of Europe and New Zealand, they have adopted this back to sleep campaign, and their incidence of risk really significantly reduced after the implementation of the back to sleep. And there's other things that are protective as well, like breastfeeding, using a pacifier. So see, it's really complicated, having a fan in the room. And so some countries even go so far as having like a risk assessment tool. They'll literally like input all that information, and then it gives you a little kind of your risk with, given your circumstances is this, and then you can make the best informed decision.
Yeah, and Sammy really kind of identified all the risk factors, and what she said so important, something that was so important was the back to sleep. And I just want to emphasize a little bit about that, because a lot of times parents will come to us and they'll have babies that spit up, or they're worried that if they put the baby on their back, will they choke, will they gag? And so this is it's very important to kind of understand the anatomy. I'm just going to get a little technical here, but it really illustrates the point, because the way when babies sleep on their back, it's actually protecting them from choking. And so the reason is because we have a breathing tube and we have a feeding tube. And so when the babies are on their back, the breathing tube is on top and the feeding tube is on bottom. So if they actually choke and milk comes upward and they regurgitate, the milk would have to go against gravity to get into their lungs. And so if they sleep on their stomach, then that happens easily. So then the feeding tube is on top and the breathing tube is on bottom. And so they can actually get food in their lungs easier. So it sounds a little counterintuitive, but our body's mechanism, the way the anatomy is, it's protective of them. It's protective for them on all accounts to sleep on their back. The main risk being, since children don't have the strength, the core control and the head control, if they flip over on their stomach, to be able to flip themselves back. And so, like Sammy was mentioning, you have a risk of something blocking your airway, whether that's the mattress or the pillows, or, that's why we don't want anything in the beds, because we don't want babies' airways to be blocked. And so that's the main reason why the biggest commonality that we see in SIDS babies are the protective mechanism is to actually sleep on your back. And it's for all of those reasons.
Mm-hmm. So I have a question about that. So it seems so counterintuitive then that pacifiers actually decrease your risk of SIDS, because there's this foreign object down in your mouth. Like, any thoughts about the mechanism for how pacifiers are helpful?
Yeah, so I mean, again, it's unclear, right? But the basic theory around SIDS has something to do with air circulation. Like, we know if a baby is on a firm sleeping surface, and if they have a fan circulating in the room and you're circulating both the oxygen that's being consumed and the carbon dioxide that's being exhaled, that you decrease the chances significantly. And a pacifier essentially is also moving air. The baby will not get into a state where they're basically just laying there without doing anything. It's giving them something to do. And so that might be part of the reason, but it's not well understood, to be honest.
Yeah, and a lot of times I kind of describe it as when babies are super congested, they're obligate nose breathers. So when they're congested, they usually don't like things in their mouth like a bottle or a pacifier, because it's harder for them to breathe. So if they are able to use the pacifier or have a bottle, that means they're able to get air in. And like Sammy was saying, I think it's the circulation of, and this is all, things that we can guess about, we don't know for sure, but improving the circulation and the air movement by them doing that suck motion, I think helps keep that air moving.
Mm-hmm. Oh, that makes sense. Thank you. So there's been a lot of studies looking at SIDS risk in breastfeeding, and we do know that amongst the babies who died from SIDS, there's a much higher odds that they were formula fed rather than breastfed. Can you talk about if that is because of the actual nutrients in breast milk being different, or if it's more the other factors that track with breastfeeding, like, more parental presence, less smoking in the parents and things like that?
Yeah. Sorry, go ahead.
Go ahead.
Okay. Yeah, no, I think it's a combination of things. And when you have multiple variables in something, you really can't isolate it to one specific thing. We know the benefits of breastfeeding. We know that it increases more bonding. It gives them a host of an immune system. We recommend right when the baby comes out to put them on the mom and do skin to skin. That skin to skin is increasing breastfeeding. It's giving them all the good bacteria from their skin and improving their immune system. So it's definitely providing that extra immune support and that extra bonding. So, yes, there's all kinds of different people in all kinds of different situations. We definitely see children that pass away, with moms that are breastfeeding, or it doesn't necessarily happen. So that correlation is difficult to make, because we have multiple risk factors in place, like the smoking and the conditions of the baby. And so I don't think it's so clear cut, in my opinion.
And I think we have to be very careful, because it's hard to be a parent. It's very hard to be a mom. You've just been through this extreme situation. You've been pregnant for 9 months or potentially less, sometimes more. And then, you have a rigorous delivery. Some people are blessed with easy deliveries, but most moms will tell you it's quite the marathon. And then you have this baby that's dependent on you. You don't really have time to recover. And so you have this baby that needs you 24 hours a day, 7 days a week. And most moms will tell you that although they might have support, many don't. And many, even if they have support, it doesn't replace the place of mom, the actual mother. So they feel that they don't have a lot of support. So I really want to be cognizant that, we're just throwing out statistics here because the questions so far have been very like data science driven. But at the end of the day, yes, we know the benefits of breastfeeding, but no, I don't want any mom to feel guilty if that was not in the cards for them. Formula is there for a reason. And most of the babies that the three of us see in our practice who are formula fed turn out just fine as well. And it's, the same with co-sleeping as well. We can present the data. We can let you know what the AAP recommends. We can let you know what statistics and what's on your side and what's not. But I would prefer a family be perfectly honest with me and not feel shamed or judged in clinic for the decisions that they've had to make because they're exhausted. Again, I'm a mom. I've had those babies, and you are not thinking straight a lot of the time. And there's no place at all for any medical professionals to shame anyone. That's just not going to help anything. Even in the worst outcome situation, it doesn't help at all for us to be like, well, you should have. That's, I feel, very, very unkind and should never be done.
Mm-hmm. Yeah, I completely agree with you. So it sounds like some of the protective factors against SIDS include pacifier use, a firm sleeping surface, no blankets or other things in the crib, keeping the room temperature to be not cold, but you don't want it to be much above 70 degrees because babies can't really regulate their body temperature, and overheating is a risk factor for SIDS. And then possibly also breastfeeding, whether it's from the nutrients or from the bonding and the increased supervision, not clear. But so knowing all of that, let's say like you are a parent whose baby is having a really hard time sleeping in their own crib, or you're just simply falling asleep while you're nursing the baby at night and you're kind of, maybe even accidentally bed sharing. Can you talk about what kind of conditions or babies are really at high risk if they do bed sharing versus babies for whom it might be safer than others?
Yeah, so it's just more of what we talked about, right? Like if they were full term versus preterm, if there's a smoking parent, if there's lots of pillows and blankets, if the surface is soft or not. So all of those contribute to safety. It's on a giant scale. And if you were to take a high risk baby and essentially like look at the statistics, and I think you might even have the statistics, but the chance of a high-risk baby dying of SIDS while sleeping in a crib in a parent's room is 1 in 1,500. So if you were to take all the risks and make them a high-risk baby, and the chance of that same high-risk baby having, dying of SIDS while sleeping in the parent's bed is 1 in 150. So it's a 10-fold increase. So even if you tried to make everything equal, which, again, that's not a perfect tool, but even if you tried to, that is present. But at the end of the day, all we can do is just recommend for parents that they do the best that they can. They be forgiving to themselves. It's okay to be tired and exhausted. If you have the ability to have something next to your bed where the baby can have their separate space and nurse them or feed them and then put them back in their separate space, that helps a lot. I can also tell you that if you really look at a baby and the way that their position is in the womb, they're really scrunched up and super, super snug and coddled, and they have no temperature changes in the womb, really, right? Like they're in a controlled environment. They're never hungry. They're never anything, right? Like it's the life being in the womb. And then you come out and suddenly you've got to eat, you've got to digest, you've got to pee and poop, you've got all these emotions, you've got temperature changes. And then your arms are flailing all over the place. If you've ever seen a newborn on a flat surface, they hate it. And that's what we're telling people to do, right? And we're saying like, put them on a flat surface. But if you put a newborn down on a flat surface, they're constantly startling. Their arms are all over the place and they're very uncomfortable and they just start to cry because it's not at all similar to the environment that was in the womb, not to mention that they always had the mom's heartbeat, which was a very soothing sound. So again, when you're having your baby close to you, skin to skin, or breastfeeding, they can hear your heartbeat, which is a soothing mechanism that emulates the womb environment. So my advice to families is get the swaddle down. If you're interested in having the baby in a separate area in your room, like the AAP recommends, it's a really good idea to try to get that swaddle down because that emulates the same feeling. Get the perfect temperature down. and see if that helps, because it usually does. If they're kind of able to break out of the swaddle, then they start to get uncomfortable. Whereas when they're next to you or close to you, again, it's slightly warmer, it's slightly more snug, and they're a little bit more curled up. They hear your heartbeat. So it's a little bit more soothing for them because it emulates that womb environment.
Yeah. And I think the biggest thing for parents is it's okay. You don't have to be scared to hold your baby and to coddle the baby and comfort the baby. I mean, all those things are good and natural. The things that you just want to be weary of is when you're getting really drowsy or when you're getting really sleepy. A lot of moms are going through, the recovery process after having this baby, whether it was a vaginal birth or C-section. They might be on pain medications. They might be on other medications. And so as long as parents are cognizant of, their awareness when they're with the baby. So, when they're fully awake, to have the baby on their stomach, skin to skin, that's, a great thing. As long as you're aware and the risk that if you fall asleep, there is a chance that the baby's airway can get blocked. So the biggest thing is to be kind of aware. And it's hard because you're breastfeeding and you're feeding formula in the middle of the night. And so I really like the idea of having room sharing, and having a little bassinet or a crib or an attachment next to the bed so that you can comfort the baby, whenever the baby needs to be comforted. But then you also have a little separate area so that the baby can be protected. And we totally endorse the swaddle. Get that down because, in the womb is a muscle, like Sammy was saying. And so when they reach out, they're used to that, that bounce back of them being comforted. And we're pretty cruel to babies when they come out because we kind of we make an environment that's completely different from the womb. So it's totally all typical and expected to go through this process.
So you mentioned swaddling. I know that you can start as soon as they're born, but at what age should you stop swaddling?
It's usually 8 weeks or when they start to roll over, whichever comes first. And that's usually the recommendation. Yeah.
About the SNU, which is kind of like, they kind of swaddle them, and as well as there's motion and sound to kind of more emulate that womb environment.
Yeah, sorry, I'm not sure I understood the question. I'm sorry.
The SNU, SNOO, or any kind of device like that, where it's like it's kind of like a swaddle on top of a bassinet that vibrates and moves to kind of emulate how they're constantly moving intrauterine.
Yes. Sorry. I thought you said, what do you think of the new, like NEW, not the SNU? Yeah. So, the jury is still out, right? Most of these things haven't been around long enough for us to have a lot of data, but most devices that are used, like the SNU or the DockATot or all of those, like typically, if you look at the AP website, they caution against those because again, they seem in theory like a potentially good idea, but we don't have the testing. The same goes for like pulse oximeters or the owlets. They're not really like held to a particular standard of safety. And so we don't have the evidence to back up its safety and efficacy. So it's hard for us to endorse them.
Okay.
And one resource parents can use is the Consumer Product Safety Commission. And so a lot of the products like the bassinets, the beds, the sleeping tools and aids, you can check if they're CPSC certified. And so, we know that those have been tested and proven and are safe, especially when assessing the SIDS rate. But the other things, might not be fully tested. We can't necessarily be sure that they are safe. So again, some people use some of these tools, but as long as that there's not evidence backing it up completely.
The recommendation for room sharing, can you explain a little bit about like why that might be? Like I've heard different theories that like one is the baby will hear the parents moving and not fall into as deep of a sleep, and that can be protective against SIDS. I've also heard that it's because of increased parental vigilance and then being, hearing if the baby's struggling or something like that. Where does that recommendation come from?
Yeah, I think there was a study that said that about, if you're room sharing and the parent is there, near the child, I think there was a statistic of almost 50% reduction in the SIDS rate. And the question is whether, this is because the parents are right there, if they notice the baby is struggling, or that they've gotten into a position that they're able to get to the baby a little quicker. And then also for increased bonding during feeding and having that increased accessibility. But that's the main thing that I've heard. But again, different strokes for different folks,
And even just so far back as three of us were training, the recommendation from the AAP was 6 months of room sharing. And then they recently, several years back, extended that to 12 months of room sharing, because they found that even more significantly reduced. It goes back to SID. Even though most 90% of SIDS cases happen in the first 6 months of life, it was still that they felt that it was best practice if you could continue it until 1 year.
Anything that you guys want to share?
Yeah, I will say one thing, right? Like the main thing here is like to really reduce mommy guilt as much as possible. And when we've had a baby and when you've been through the rigors of labor and then you have a baby that needs you so much, sometimes like decision making and stuff is hard at that time because you're truly just in survival mode. So I do recommend, like, if someone were to listen to this live, I would love for it to be before they've even had the baby, because that's when you can listen with open ears and a clear mind. And then remember, nothing is going to go according to plan. Your birth plan might go out the window, and everything that you thought you might not do or say when you were pregnant to your child and how you raise your child, like, it's such a humbling experience. And so just remember all of that. And at the end of the day, remember everyone's doing the best they can. Anna touched on it so beautifully. There's so many different cultures and so many different ways to raise a baby. There is really no right or wrong way. We have to get away from this whole mommy shaming culture and just remember that when pediatricians are talking to you, they're coming from a good place. They're just giving you facts and statistics. They might have seen a couple of things that have broken their hearts along the way, and they're doing the best that they also can to prevent something like that from happening in the future. And that's all well-meaning. But at the end of the day, we totally understand that we've not walked a day in your footsteps. We don't know what brought you to the position that you're in right now, and you're doing the best you can with all of your life experiences for you and your baby. I think that's a take-home message.
Yeah. And that's kind of why we did this, because we only get a few minutes in the office and we're kind of scramming in all the information. We're like, we're giving you all the tools, and it can definitely cause a lot of fear in parents, and they're overwhelmed. They're tired. They're trying to do the best for their baby. They're absorbing this information. So what a lot of pediatricians do, we repeat a lot of things. We talk about it at every visit. We see babies in the beginning every couple of months. And so it's the biggest take home, like Sammy said so well, is that, is not to incite more fear. People have been raising babies till the beginning of time, and they have done it without all these fancy things that we have right now. They've done it, and they've done it well. So we are in no place to judge. It's been from the beginning of time, and so all we can do is provide that information, but it's all coming from a place of support and not to make anyone feel extra guilty, because parenting is hard enough.
This discussion falls the same line of, remember to wear a helmet when your kids are riding a bike, or leave a baby unattended in a bathtub or a swimming pool. Please. That's what we do. This is our profession, what we call anticipatory guidance. But then at the end of the day, you go home and you make the decisions that work best for you.
Thank you so much for being here. So once I upload this webinar video to my website, I'll also link it with a couple of the articles that we talked about. So if anybody wants to actually read those articles themselves and understand the stats behind what we're talking about, you can totally do that, help make more of an informed choice. And then I just want to encourage everybody who's watching to make sure you follow at the PD Pals. Thank you so much to Dr. Samira and Dr. Anna for joining us today.
Thank you, Leah.
Thank you so much.
Have a wonderful day.